went a little extensive on the AMH because there are so many things which are very misinterpreted with AMH. Like for example, hypoc. We should never try to interpret AMH and take any decision. As you start stimulating hypoc, the AMH will go up rather. That's one point to be remembered. And obesity and AMH. This is one current. We are not taking a separate lecture on obesity, but that is one thing I just want to cover in 2-3 sentences. See, having a very obese commonly will have low AMH. Because of obesity, there is a chronic state of inflammation, and a lot of follicles will keep getting recruited, and there will be an accelerated fall of antral follicle count. So AMH generally will be low, unless you have an obesity with polycystic ovary syndrome. So it is worth going for a bariatric surgery or a very drastic measure for somebody who is obesity and polycystic ovary. For somebody who has a low AMH, if you do, and she has morbid obesity, I'm obviously talking of something like BMIs of 38 and 40 and 45 kind of BMIs with 100 kg and 120 kg. Which is not amenable to diet alone and not amenable to even pharmacotherapy for obesity like GLP-1 agonist, where you may have to recommend obesity surgery. Obesity surgery is going to postpone her pregnancy by 1 year because of vitamin deficiencies to overcome. And in 1 year, she will lose about 30-40 kg. But with that, AMH is going to come down and her yield of follicle is also going to come down. So it is a very, I would say, tragic thing that with obesity, with morbid obesity, what Richard Legros recently in 2024, in I think ASRM or ASHRAE, they put it up, that they said fertility first and fat next. So improving obesity will improve live birth rate, but fertility is hampered badly. So it is better to go for fertility first. That means you're going to do IVF first, in spite of she being 120 kg. Most of the literature which is published on obese women and infertility talks of, like NHS or any guideline, like BMI beyond 35, don't do ovulation induction. So they are avoiding ovulation induction because of risk of fetal defects, diabetes, placental insufficiencies, poorer outcomes, etc. So they say don't do ovulation induction. But nobody has put up a guideline, don't do IVF. So the risk, so IVF is without, it's no guideline is covering IVF. They don't say don't do IVF. So IVF is possible. So what is the problem? It is the anesthesia. Okay, anesthesia in a morbid obese lady. But now we give anesthesia for bypasses. We give anesthesia with a ejection fraction of 15 and 20%. We give anesthesia for craniotomies, etc. So the risk of anesthesia is pretty low that way. And there are competent anesthesiologists which are available for morbid obesity. They will give for bariatric surgeries as well, which last for 2 hours and 3 hours, while this procedure is going to last such a small time. So the whole scenario of morbid obesity and fertility has changed to fertility first, fat next, because of this association of a drastic fall of AMH, which is noticed with this. Very easy takers for all of us, but very difficult for a patient to digest fertility first for this. They always have that notion that we have to reduce weight. But no trial of diet has ever been successful because you need a double-digit fall in weight. Very handful can achieve a double-digit fall. And the best of the trials, let me quote this trial. They conducted this trial wherein it's at a European university, I'm forgetting the name. They published a book, a diet book. About 3 students were doing PhD on that trial. It was a randomized trial on diet and obesity and fertility. And they executed every part of it very beautifully. But at the end of the trial, 63% was the attrition rate in the trial. So 63% of the patients, in spite of rolling, came out of the trial. That tells you the commitment of a client to do a diet control to reduce weight. With 60, more than 2/3 of the client want to say, I don't want to participate in such a trial. So it is, there is no point being very, very pushy on diet and getting them controlled. You can rather take help of GLP-1 agonists. How many of you are using GLP-1 agonists in practice? Make it a practice. Please use it. They're good drug. Ribulsus is one good drug. Liraglutide. If time permits, we will take a small 5-minute talk on how to use these drugs. We use it very commonly, at least for the indicated ones, we do give this suggestion that they can go for a liraglutide or GLP-1 agonistin therapy. Anyway, I'm going back to a few physiological concepts, and this is little tips and bits I'm going to tell you about different aspects. We'll first study what is LH surge. How do we define LH surge? It's very important for us to define LH surge because we are going to do true natural cycle embryo transfer cycle. So defining LH surge is very important for us. Various definitions have been in practice, like the LH going 3 times beyond the basal line, LH level beyond 17, and LH level beyond 20, LH going beyond 20 with progesterone up. So various definitions have been established. We'll look at the classical definitions which are accepted in the literature today. So this is a beautiful paper. I would highly recommend all of you to read this paper. This is the ART, the frozen embryo transfer. They say that best to go for true natural. And yesterday only me and Dr. Shariu were discussing about to go with like most of our ART, FETs are, I would say at least about 80-90% are letrozole stimulated FETs. But we are seriously, after we had a discussion yesterday, we are thinking that we should go for true natural FETs. They're going to be more, it will be better for all of us. And I think Shariu is covering a lecture on that. So we will address that thing again. So this is one of the theories of how to define a LH surge. He said day 1, when the start of the LH rises there, you will have an LH level which is going up. E2 is already up because the dominant follicle is there and progesterone is not there at all. Second, the LH will be up. By that time, this LH has acted on the granulosa cells, and those granulosa cells have become lutein cells. Because they have become lutein cells, they have stopped secreting estrogen. So there will be a drop in the estrogen, and progesterone is still not risen up. And the next will be LH up, E2 is down, and now the progesterone comes up. So when this is there, this is your LH surge. Day 1 of LH surge is this is the LH surge. That LH is up, E2 is up. Okay, but this is diagnosed retrospectively only if this change takes place on the second day, where E2 drops by nearly about 30%. Okay, but this change is not seen classically a day-long change in every lady. This drop in E2 can last for some time. Sometimes the E2 doesn't go down very drastically also. So you have to be very careful in interpretation. So the second interpretation is, suppose you don't notice this, then do you notice the progesterone going up? And if the progesterone goes up beyond 1 nanogram, you say, well, the progesterone is going up, and that could be the day of ovulation. Then you can time the transfers up. So doing multiple tests and interpretation becomes a little difficult. But what I want to convey you is ovulation means E2s are down because of luteinization of the granulosa cell. And that comes, this particular paper was derived from this particular study by Irani et al. A very beautiful study of optimal parameters for determining LH surge in natural cycles. Sometimes I wonder, well, these people have done such basic research cycles, questioning the basic way we learned our physiology and questioned that thought process and tried to prove it up. And they had 2 groups they made. Okay, they made group A and group B. In group A, LH is beyond 17, E2 is high. In group B, LH is beyond 17, higher than group A. And E2 is less than 30% of group A. And they said that, well, when they looked at the LH levels were higher in the group B. When the E2s have come down, and that's why they say that is the day of your surge. That's a physiological way of understanding what an LH surge is. I'm not going to go through this. So rising E2 will induce LH surge. Now we say that does the rising E2, that's what we learned in Spiroff, isn't it? If estradiol levels are beyond 200 picogram for 50 hours, the LH surge will take place. But believe me, there is no estrogen receptor in hypothalamus. Then how does it come down? There is no estrogen receptor. So there are progesterone things. So it is the small amount of progesterone which goes up. And that small rise in progesterone, pre-ovulatory, is responsible for kick-starting the LH surge and not the estrogen alone. Estrogen alone will take the LH up because it's a positive feedback. But it will not cause a surge kind of surge. It is the progesterone which is needed to cause that surge. So the orchestra is so beautiful. From where does the progesterone come? So you have, I told you, DHEAS, pregnenolone, progesterone, androstenedione, aromatase, estradiol. Now, if aromatase activity is performing to the peak and you are still producing androgens, not all androgens are getting converted. That means your follicle is maturing, it's to the peak, pinnacle of performance of the follicle. So, androstenedione backfires, progesterone also backfires in the sense accumulates. So, androstenedione is not getting converted. Because androstenedione is not getting converted, the progesterone will not get converted. Progesterone in the follicle will accumulate. And this progesterone, everything is done in theca cells, which are next to the vessels. Granulosa is not next to the vessels. So, this progesterone now leaks into systemic circulation and small progesterone rise takes place. That reaches the brain and causes the trigger, the orchestra. So, that progesterone small rise signifies that the follicle maturation as its pinnacle. Okay. Now, let us put this into clinical practice. Where do we put it? So, Dr. Shari will deal with it, how it is put in frozen embryo transfer cycle. I am not going to do that, but I am going to tell you the other part of the story, that the progesterone rise which takes place on the day of HCG in IVF cycle, take it as a good sign. We are taking it as a bad sign. No, it is a good sign. That means you have stimulated the maturation of the follicle to its pinnacle. And multiple follicles are growing. So, multiple small amounts of progesterone, cumulatively the progesterone level will go high. And the Vinity study of 60,000 IVF cycles, retrospective analysis said, if the day of HCG progesterone is beyond 1.5, statistically significant drop in pregnancy rate is there. The progesterone does not affect the egg, it does not affect the embryo, progesterone affects the endometrium. And because the endometrium receptivity is lost, the implantation of fresh embryo transfer does not take place. So, our policy is to do frozen. If you are doing frozen, there is no need to estimate the progesterone. So, but everybody knows that the progesterone on the day of HCG hampers the fresh embryo transfer implantation. But nobody knows what is the level of progesterone affecting each patient. For example, Grisinger repeated the study. And he said, in patients who are high responders, if the follicles are beyond 15, and if you are doing a blastocyst transfer, your progesterone till 2.75 on the day of HCG trigger does not affect the fresh embryo transfer pregnancy rate. Why? With 15 follicles, the estrogen is so much that just 1.5 nanogram of progesterone does not induce bad changes. You require a higher progesterone to induce a bad change. But in a poor responder with 2 or 3 follicles and progesterone beyond 0.8 will start hampering the pregnancy rate with fresh embryo transfer cycles. You understood this? So, everybody knows progesterone affects it. Nobody knows what, in which patient, what E2, what follicle, what level will affect it. Okay? So, and this level in a poor ovarian reserve patient will be lower than 1.5. So, just because a low ovarian reserve patient having 4 follicles has a progesterone level of 1.2, don't think that it's safe to do fresh embryo transfer cycle. No, probably her cutoff is 0.8. Now, this doesn't matter much to us because at all our centers we do freeze-all protocol. So, it doesn't matter much to us. But if you are planning fresh embryo transfer, this will have to be taken in consideration. We will discuss this in a little more detail as we go ahead in this simulation.
Any higher limit of progesterone on the day of
Today's patient, I did a pickup in the morning. Her progesterone was 5.48. Am I right? Her progesterone was 5.48. E2 was 4,900. You said LH was 1.9, and progesterone on day of trigger was 5.98, and I was 5.48, and I was very happy. If the progesterone is high, I am very happy because my match stimulation is to its pinnacle. So, in egg donor cycle, let's come to egg donor cycle. Do I do progesterone? There is no need to do progesterone because you're not going to do transfers anyway. But I would prefer doing a progesterone for an egg donor cycle. Suppose I can see 7 follicles, egg donors will have 15 follicles, and her progesterone is 0.7. So I tell my doctor, give one more day of stimulation. This is next day progesterone is 1.2. I said, good, let's trigger her. So that indicates your stimulation has reached its pinnacle. In somewhere, progesterone, again, they looked at the euploidy rates, better. M2 oocytes obtained with high progesterone, better euploidy. So progesterone with cumulative live birth rate in a higher progesterone, with all frozen transfers, best pregnancy rate. But if you do one fresh and rest frozen, pregnancy rate drop because your fresh transfer is hampering the results. You understood this whole thing? Yeah. This is one thing we all understand, especially the ones when we are all doing antagonist cycles, that the follicle recruitment, since morning I'm telling you the same thing, the follicle recruitment starts prior to the onset of menses, maybe -3, -7 days. And then you start stimulating. Your stimulations, if you're doing from day 2, you are causing 2 waves of folliculogenesis, one which started here, one which started here. So you will have a asynchrony of follicle beyond day 8 of stimulation. And you don't want this. If you don't want this, there are 2 ways of correcting it. You do something here that the FSH doesn't go up, and the simplest thing to do is to put estrogen tablets. Or you do something here that they don't rupture. So best is to do antagonists for a prolonged time. So both the studies are having an E2 pretreatment or giving 1 more day of stimulation have both resulted into more fertilization rates, more metaphase 2 oocytes. So hardly any time, like Manan has also worked with us, hardly any time we give 9 days of stimulation. Most of our stimulations in IVF go standard for 11 to 14 days. Okay, because giving that 1 extra day of stimulation is always beneficial in getting more metaphase 2 and more oocytes. So if you're doing an antagonist protocol, this is what you see. You always see an asynchrony of follicles to start with. If you do an agonist protocol, because you have given GnRH agonist for 7 to 8 days and you have caused gonadotrophin specific hypophysectomy, there is no FSH, no LH prior to the onset of menses, so all follicles are alike. And when you, let's say, put both the patients on the same stimulation dose, there will be a slower rise of E2. There will be a faster rise of E2 because some follicles are bigger. But at the peak, on the day of HCG, this E2 will be higher than this because all the follicles are mature and they are secreting a higher amount of E2. So there is the dynamics of follicular stimulation are different in antagonist and agonist cycle, and that results in this particular problem. In agonist, all the follicles are lined up, tuk, same size, because they all started off same. Well, in antagonist, you will have asynchrony. Okay, and this was not well understood by a lot of people at the start of introduction of antagonist in practice. It came in about 2005. But trust me, antagonists were discovered before agonist. Antagonist was available only as injection. And antagonist used to produce a lot of reaction. Local histamine release was very high. So it was not used. And agonist was preferred. And I think we were taken for a ride. The whole IVF world was taken for a ride on giving agonist. Instead of agonist, if we were told give E2 pretreatment, we would have done better jobs. We will discuss this again, why I'm saying so. Okay. So FSH receptor is saturated after exposure to particular amount of FSH, and receptor binding designated, especially about 20-22 MIU. It's satisfied. So in all our IVF cycles, presently, we are doing an FSH level on the day of trigger. You will ask me why. We want to know where we have reached the pinnacle. Are we touching here? Because many patients are going to require a second IVF cycle because of lack of blastocysts, PGTA, PGTM, 100% 2 cycles are needed. Or you may face Posidon 1, and patient will say, well, you always told, yes, good, and I just got 4x. What went wrong? So you have to protect yourself saying that nothing went wrong. So I did my FSH level, which is 22 for you. That means our stimulation is at its peak. Even if that 22 level goes to 36, I'm not going to achieve anything beyond to you because we have reached the pinnacle. But if your FSH level is 12, then you say, well, I used the dose appropriate for your body mass index, your age and your ovarian reserve, but we still did not reach the pinnacle. That means the metabolism of these drugs in your body is something different, and that could be responsible for a lower output. We can do second cycle, forget the concessions, I need to use higher doses to you, and the cost of treatment is going to go up. So it's very important to know. This is one test not mentioned in the books. We do it ourselves because it's not possible to do an RCT on something like that. Okay, but this is good tool for counseling our clients, and that's why we prefer doing FSH on the day of trigger. FSH at the time of recruitment is important. Later increases may not do much. This is a very important statement. Tilburg et al. Did a study of studying the amount of drug needed for patients with low ovarian reserve. And they classified into 2 groups, FSH high, FSH normal, and age high and age normal with low ovarian reserve constant. And they said they use 150 IU as their standard stimulation. and 57% of the patients in the next cycle needed a step up of dose, and 49% of the patient during the course of stimulation needed a step up of the dose. What does that mean? That if you start with a lower dose, more likely you need to step up the dose. Otherwise, you may have to land up in cancelling the cycle. Cancelling cycle means it's a failure, and a failure more reflecting on the doctor than the patient. Okay. So many of us will start at particular dose, let's say 225 IU. Halfway through, you say, nahi, acha recruitment nahi hai, let's make it 450 IU. Now, what is happening? There's some follicles, threshold was reached, they started growing with 225 IU. They have grown to about 7-8 millimeters. Few follicles are still at 5-6 and they have not responded. Now you start off, now they start growing. But they are going to reach the pinnacle for 10 days from today. That means 5 days ka kha chuki patient, 10 days, so your stimulation is going to go for 15 days. And if you want to go trigger for 13 days as from the previous start of the stimulation, you're going to face a lot of asynchrony. So any step up of the dose halfway through is always adding to your asynchrony. So better to use higher doses right from the beginning rather than doing halfway through increases. My fellows are here, ask them, we hardly do halfway through increase. Hardly in my practice I would be doing a halfway through increase. We always use a same dose throughout the period, and we always give a full throttle stimulation. Go high, go full. Follicle consequences of any dose changes are not seen for 4 days. IVF cycle length is 12 days. Dose change itself, the policy is questionable. The kind of, I'm sorry, I'm going to jump ideas, so please allow me to jump ideas because we are discussing different physiological topics. I think I would love to discuss this for 7-8 days also. It will be fun, talk going, but that will be more of physiology, and we are all gynecologists and super specialists. Discussing this becomes difficult sometimes. And FSH in the body is secreted as a molecule which has glucose moiety in it, and it has 4 carbohydrate terminals. To the carbohydrate terminals, sialic acid residues are attached to that, or carboxy terminals to which sialic acid is attached. So you could have a very complex FSH molecule with more sialic acid attached to that. Okay, and that is called acidic isoform. While you could have an FSH molecule with less sialic acid attached to it, it's a simple molecule. It is called a basic, or let's not call it basic, let's call it less acidic. Being a complex isoform of FSH, highly acidic, this is being a complex molecule, does not get degraded in the liver, and neither it gets excreted very fast. It lasts in the body for a longer time, so it has a long half-life. And it's complex, so the receptor affinity is less, so its action is less, bioavailability is less, and action is long. So induction of aromatase is less, while the action is long. While you have a less acidic molecule, the receptor affinity is better, so the action is to its fullest, but it gets degraded very fast in the liver and is excreted fast. So the half-life is short. You understood this? Human body secretes different isoforms. So a high FSH acidic isoform is secreted in the early part of the follicular phase and the late luteal phase because you require a higher level of FSH. We studied in the morning. You require a higher FSH body levels to push the follicle. The car is at 0 speed. You require a good accelerator. Halfway through the stimulation, the car is at a reasonable speed. You don't require a good stimulation there. While in the middle part, around the periovulatory, you have a low acidic isoform. So it lasts, so the FSH level drop. Even it drops, the action is very good because it is more bioavailable. Sadly, we do not develop or we do not give such different kinds of isoforms to our patients. There are only 2 isoforms available to us. One from the menopausal urine, which is highly acidic. So all the women who have premature ovarian failures, POI or menopause produce a highly acidic molecule of FSH, and that is extracted for us. The one which is recombinant is the least acidic molecule, or your RFSH, that is Recagon, Gonalef, your Folisurge and Foligraph, whatever recombinant FSH you use. You know now the difference why recombinant have a fuller action, because it is more bioavailable. So being more bioavailable, it keeps on raising the FSH level because every day you're giving injections. It's going to last for a short amount of time, but every day you're giving it. So collectively, the FSH action is very strong, and more follicles get recruited through the cycle. But if you use human menopausal gonadotropin, use an acidic molecule, it will not be that strong. So if you want to use lower doses and you are interested only 2-3 follicles, like an IUI, using recombinant will be better, because at a low dose also a good amount of aromatase induction will be there. But if you are using higher doses, it wouldn't matter much, because follicle number thoda bahut kam hoga. At the end, if you are transferring good embryos, your pregnancy rate still will be good. That we will again start debate. What I want to point out here is, have you heard, are you people attending the webinar called by Jayesh Amin, Extraordinary? You're not, okay. So there is a typical Indian protocol used is they give recombinant FSH for the first 5 days and HMG in the next 5 days to cost save the thing. Okay, now what are you doing? Are we supposed to use recombinant here? No. We are supposed to use a highly acidic molecule. So we are going completely opposite the physiology. We are using a low acidic here and a high acidic here, which is not physiology. Physiology said high acidic and thus. So mixing recombinant FSH and HMG is like mixing apples and oranges. We don't do that at all in our practice. We do mix recombinant FSH and HMG, but recombinant FSH and HMG is mixed from day one continuously. It is not halfway through you come down, or you are coming down from a very highly biological activity to a low biological activity. Some follicles may not do well. You understood this concept? Yeah. So this is a paper on characterization of follicle stimulating hormone profiles in normal ovulating women, and they say that, FSH estimated on all these days. 26 out of 326 patients, first USG was performed after ovulation, a short cycle was missed or whatever. Yeah. So these are the different FSH patterns, how they exist. A typical pattern is first few days high, then later follicle phase low, then a small FSH surge with LH surge, and FSH will be low to nadir in the luteal phase. But not every lady is like that. Look at the different patterns. Why do you think there are different patterns? Are these diseases? No, they are not diseases. These are normal variations. As we have different noses or different heights and different hair color, I don't have hair. So similarly, these are different patterns which are there. And this is your emotions. This could be in the most happiness. Then you go to the hostel. Then the first MBBS exam. Okay? On top of that, sedentary lifestyle, burgers, Zomato buy, serving you, and now you grow weight. FSH still becomes like this, and now you become pakka anovulatory PCO. Irregular cycles, stress uska bhi hone lagta hai, kyun irregular cycles hai. So what I'm telling is, your psyche, your hypothalamus all plays a role. People, you will commonly have patients who will not conceive. You're trying your best, they're not conceiving for 6 months, and then they say, can I take a break? And you say, okay, go ahead, take a break, and they conceive in the break and come back. So you need to tell your patients, so we commonly tell, कि your ovarian problems is managed by pituitary. But who manages pituitary? Hypothalamus. Well, who manages hypothalamus for that matter? Not spinothalamic tracts. The hypothalamus is managed by the cranial nerves. So what you hear, how much you sleep, how much is satiety, how much you exercise. So if you can regularize these things, probably that regularization will percolate down to your ovary, and you could conceive better and you could have ovulatory cycles. And that is your yoga, pranayam, all acting at that level. Give it a allopathy touch or a scientific touch to that, then they will come back and say, well doctor, good you told us, we did that and we conceived. Otherwise they'll say, आपको 2 लाख आपके पास waste हो गया, ऐसा ही मिल गया, वो बाबा जी बोला ऐसा जप माल करो, मिल गया pregnancy. No? So what about luteinizing hormone surges? So this is a nice paper again, relationship between luteinizing hormone surge and other characteristics of menstrual cycle in normal ovulating women. I'm just telling you, in normal ovulating women, what are the different kinds of LH surge and amplitude. LH surge and amplitude vary widely. Like it is from 2.5 to 14 to 8 times amplitude duration. From 2 to 11 days, the surge has lasted for 11 days, imagine. Okay, so the human body is like that, where it is all interdependent orchestra. and the LH can vary. So what is a normal LH surge? It goes up for maybe 14 hours. It lasts for 16 hours and come down by 16 hours. Okay, so as it starts going up, for the first 20 MIU, it causes meiosis is complete. It reaches 60 to 80 MIU, it causes ovulation. It maintains 40, 60 MIU, it causes luteinization of all granulosa cells. By this time, your progesterone is going up, and that is telling pituitary goodbye, shut off, and your LH starts dropping down. Unless the follicle or the corpus luteum is rescued by HCG from blastocyst. Does blastocyst secrete HCG? Yes, it secretes HCG. Okay, and it's a hyperglycosylated HCG, which is a more stimulation for the corpus. God is great. The molecule of HCG is different when it comes from a blastocyst and that which comes from the other this. So let me talk of HCG here itself. What we add to the ampule of HMG. So when you start purifying urine, the LH is lost as you purify more and more of FSH, and FSH also loses a few sialic acid. So highly purified HMG means an FSH molecule which is less acidic, but not as less acidic as RFSH, but less acidic than a simple, not highly purified. But in the bargain, LH is lost. So to add LH, we have to add HCG, as I told you, menopure. But this HCG comes from where? So there are two sources of HCG, pregnant urine or menopausal urine. They here use menopausal urine as HCG source, not pregnant urine. The pregnant urine HCG is hyperglycosylated HCG, and that product is called Marioford. It is not yet introduced in India. It's available now in UK. So that has a better LH activity than what we use here. You got it? I don't know how many of you are using Menopure. Use Menopure for few of your patients. See the benefit. Oh, chandiye. The eggs grow beautifully. You don't have any troubles the moment you use correct products. I don't have share in Ferring Pharma. Look at the LH. Not every LH is simple, you know. There is an LH. There are different kinds of LH. There is a single peak like this for 48% of women, and they're all normal menstruating women, by the way. They're not infertile women, they are normal women. But the LH surge is different in every lady. There is a double peak in 33, plateauing 11%, multiple peaks. That is the reason the cycles go up and down for many women by going to hostel, some viral fevers, dengue, hospital admission, boyfriend ditching, new boyfriend troubling. You know, your LH surge will alter and cycles can go here and there. Okay? So this we have to remember that's why we do modified natural embryo transfer. We take the control of the LH surge in our hands. So we can time our embryo transfers and this particular thing, and as it is, our lady is going to be in stress. She's going to be in stress and doing multiple tests, as I told you, 3 days blood test, which is difficult. So might as well give HCG and do a transfer, make the whole life much, much simpler. So low FSH variation with good sleep patterns, high BMI, there is an increased FSH variability and increased physical activity and increase with physical activity. God knows, I'm not able to say this. FSH peak before day 2, 25% of the cycle. Between day 2 and day 3 is 28%, day 4, 47%, 13% prior to menses. FSH decline in late follicular phase was seen for all these normal menstruating women have such different kinds of FSH peaks. So imagine FSH peak on day 2 itself. That means the follicle must have started at -5, -6 days. Isn't it? So every cycle is different in every lady, in the same lady at different ages, and the same lady with different weights. As her weight goes up and down, the normal menstrual cycle patterns will be different. Let's talk of luteal phase. I told you about luteal phase, that there is always a mid-luteal surge of progesterone, isn't it? The follicle will rupture, LH will plateau, so it will start luteinizing all cells. So the progesterone will slowly go up. Mid-luteal, there will be a peak of progesterone. This will tell the pituitary to stop LH, and then the progesterone level will go down. This is the late luteal. Progesterone comes down. Because progesterone comes down, GnRH pulsatility starts, and the new follicular wave starts. But in a stimulated cycle, what happens? In a stimulated cycle, you have probably one or two follicles. Imagine there are 2 follicles. With 2 follicles in a stimulated cycle, the progesterone is coming from 2 follicles, not 1. So the progesterone is much, much higher. On top of that, you give HCG. HCG acts selectively. 90% of the HCG acts on a cyclic AMP pathway, 10% on the ERK pathway. Your high LH surge acts 90% on ERK pathway and 10% on cyclic AMP. The difference is a cyclic AMP pathway stimulated is more steroidogenic pathway. So you have a much higher, faster rise of progesterone. As early as 2 hours, they have seen progesterone going up with HCG injection. So the progesterone goes up very fast. So the progesterone peak is not mid-luteal, it's early luteal. Moment you have an early luteal progesterone peak, it tells the pituitary, shut off. LH comes down. So then what you have? You have a mid-luteal fall in progesterone. So what are you doing everything for? To get a pregnancy. And what are you doing at implantation? You're screwing it up, the whole process. You're getting it up? Okay, by stimulating, so don't ask question, this patient needs luteal phase support or doesn't need. Everybody, if you're doing a stimulated cycle, everybody needs a good luteal phase support. Just get it ingrained into your brain.
Sorry. Here already the progesterone is high. If suppose we give, when will you start the progesterone after the HCG?
Yeah, exactly. I'm coming to that. After this, we'll answer that question. So this is what happens if you give HCG trigger. Awkward situation, isn't it? We have a loose control. There's an implantation window. The blastocyst is going to come day 6 to day 8 after the trigger. Am I right? It takes 5 days to form the blastocyst. 36 hours after the trigger, the rupture happens. So 7 days. So HCG you are given, the HCG goes up, remains for day 6, the FCG will be there. Now HCG support is gone. The progesterone achieved by HCG is very, very high because it's cyclic AMP pathway. That progesterone has already told LH to be shutting off also. So there is no innate LH, there is no HCG action is gone. So and HCG of pregnancy is going to take another 1 or 2 days here and there to rise up adequately. So you are creating what is called a luteal hole, and which is not going to, and that is exactly you don't need to take place. Okay, so coming back to your question, in patients, if you have given HCG and it's a TIC cycle, timed intercourse cycle, my advice is please have intercourse before I give you HCG. Because if I'm saying in 2 to 4 hours progesterone is going to go up, it is going to make the cervical mucus hostile very fast and your sperms will not be able to go in. So the patient lands up at 12 o'clock to your clinic, you give HCG, आज रात को 11 बजे संबंध रखो, कुछ नहीं होने वाला है. होगा नहीं होगा पता नहीं, but less likely. There's nothing absolute in our science. So I always tell them to have intercourse when they are coming for us to monitoring. That is the best. Even in IUI cycles, I tell them always to have intercourse. This sperm or that sperm, whichever, of the same person. Okay, so we always tell them to have in the late estrogenic phase, the right time to have intercourse. So now this patient I'm giving HCG, and then I tell them after 2 days you start your progesterone. So on the day of pickup, or a day of IUI. Even if I'm not doing IU, after 2 days I tell them you start progesterone. They will start dufaston or micro, whatever is their choice, and whatever choice we come up to, that is started. Give it for 14 days, do a pregnancy test, positive, negative, band karo baad mein. That kind of approach we follow. Exactly, this was the answer.
Sorry, sir, a little more expensive. Already the progesterone is high. Now we are giving progesterone after 2 days. Will it not shift the window of implantation on the
You are actually right here, but that is probably one of the reasons why the earlier studies, when they did with clomiphene and with HCG trigger, there was no improvement in the pregnancy rate noted. Because this is one, but not everybody's window of implantation will shift. Secondly, window of implantation is very precise only in HRT cycles. It is not precise when you have your own follicle and corpus luteum. There's a wider window of implantation, and probably that is the reason we don't see such absolute terminologies existing. That's the reason.
Is there any progesterone beyond which you feel it is idle?
I'm discussing non-IVF for timed intercourse cycle, nothing of that sort. Neither do we estimate progesterone levels, to be very frank. If you go through the patients who have gone HRT cycles, when you are given progesterone, there have been studies, very few studies, we are talking of a high progesterone level associated with a lesser pregnancy rate. They don't say no pregnancy. They divided the progesterone levels into different quartiles. And when you have a very high progesterone level on the day of embryo transfer, that quartile had a lesser pregnancy than the earlier one. That's how it has been described. Otherwise, there are no absolute cutoffs of progesterone level, higher cutoff not to transfer. For a lower, yes, you have. For a higher, you don't. But I think Dr. Shari will do that in much more details. So mid-luteal will have all these, but we don't supply hydroxyprogesterone to our patients externally. Luteal phase, all stimulation cycles, luteal phase of all stimulation cycle is disrupted. So I don't want to go into debate about that. We will just supplement the luteal phase. Mid-luteal LH levels in the natural cycle is about 6 IU. GnRH agonist trigger, it drops drastically. Dr. Shari will tell you that. HCG trigger also very low. HCG का क्या होता है? With HCG level goes on, it down regulates the LH receptor. Okay, so LH is very, very low. But then it wouldn't make a difference because HCG is high, that is acting as a surrogate. And we expect HCG to be there on day 8, 9 of implantation. This is just. So this is what happens in HCG trigger. 12 hours of HCG trigger, HCG level goes to about 120 MIU. These are various studies done in IVF. 12 hours after HCG, they have taken the serum for HCG estimation. And patients who had an HCG level less than 60 MIU, they had less metaphase 2 oocytes. Okay, so a good level is to have about 80 to 130 is a very good HCG level to have. We don't do that in our practice. This is just a theoretical thing. But imagine 120 MIU HCG, that means about 800 IU of LH. Huge LH is there. So P2 peak, there will be a progesterone peak, it will fall down. And this 6.5, the HCG progesterone will go down and implantation will be around this area. And this is a window where there's a luteal phase deficiency. This is a theoretical thing. And then we should add progesterone, covering same thing. Okay, next topic. Sorry, we stop at that, we go to another thing. We try to understand the dynamics and hormone production of the antral follicles as they grow. कितना बजा है? अच्छा, और एक 10-15 मिनट के बाद लंच ब्रेक चलेगा ना? हाँ, ये वर विचारून घ्या, ते बंद करत नाहीत ना? त्यांना एक 15-20 मिनिट लागतो. Now this is one concept I really want you people to understand very, very well. Okay? Yeah. कहाँ करून? अशोक त्यांच्या सयाजीच्या माणसाला AC जरा टेम्परेचर वाढवायला सांगा. वो कॉम्प्युटर्स रहते हैं, प्रॉपर सजेशन देना पड़ता. I call all my staff computers, because if you tell you didn't do this, आपने बोला ही नहीं. So no, you have to give a perfect instruction. So he will decrease the temperature also. Okay. Now, this is the LH surge which is routinely taking place. Okay. And I told you that with LH surge, there will be a small rise in FSH. And this FSH will recruit another wave of follicles. We studied this in the morning. And that follicle can go up to 12-14 millimeter. Generally, this follicle will disappear by the time she gets her next menses. And this is called luteal phase dominant follicle. Okay, this is a story commonly exists with everybody. In some ladies, this follicle will cross over and will be dominant even in the early follicular phase. You'll cross over the menses. Now, it is your atypical luteal phase dominant follicle. We don't use this complex terminology in practice. We call it residual follicle. Am I right? So, and once we see residual follicle, we say this is bad, or this lady is, is a harmful thing. We won't start our IUI stimulation. We won't start our IVF stimulation also. People debate, and I see a lot of YouTubers telling about, aspirate the follicles, do an E2 level. E2 level is so and so. Or give antagonist for 4 days and then start stimulation, etc., etc., etc. I am telling you a physiology. Just follow this. You have an atypical luteal. So, what is this secreting? This follicle is secreting more amount of estrogen. So, nature is giving you late luteal estrogen. Am I right? Nature is giving you late luteal estrogen, and that estrogen will not allow this FSH to go up, which is supposed to go up in the late luteal. It will become small. So this residual follicle, what is it giving you? The nature gifted synchrony. Okay, start your stimulation. Neglect that follicle and start your stimulation. Even it is IUI, simple stimulations or this, just neglect the follicle. If you are very, very conscious, get a progesterone level done. Especially if it is an IUI or a timed intercourse cycle, because if the progesterone level is high, pregnancy is not possible. Otherwise, the IVF cycle, don't even get a progesterone level done. Just start off your stimulation. So I love a residual follicle. It is very healthy thing. It is the best thing to have. Nature helps you out.
What is the progesterone cutoff?
I say 1. But there is no studies on that. This is just an, my take, you can say, but there is no studies on that. With women aging, reduction in AMH and inhibin, loss of negative feedback, greater tendency of a polyovulation would be there. Luteal phase dominant will be seen in about 30-40% of older women. Older the lady, bigger is the diameter of the follicle, and old women with second rise of E2 in mid-late luteal phase is also there. So, this is because the dominant follicle which persists. So, older women will commonly have these residual follicles. Don't bother, go ahead. Major follicular wave, progressive increase in, subsequent decrease in AFC will be there. A typical LPDF follicle grows to this, luteal phase reaches 16 millimeter, regresses prior to menses. Atypical, the one which persists in the next follicle phase. This affects the FSH E2 levels. Follicular E2 more in atypical, while follicular FSH more in atypical. Advanced age women, again atypical will be more. Same story I'm telling you, that high E2 in atypical LPD will suppress progesterone production also. That's pretty good actually, So what my message to you all is, if you have a residual follicle, change your attitude. It is not a foe, it's a friend. So go ahead and don't miss on that particular cycle. I think I'll stop. I'll just take, I'll finish. This is a very small topic. I'll just take it. And, uterine peristalsis. I want you people to click a photo of this. It's a free of charge available on net. Please go through this paper. I have not seen a single paper as beautiful as this on uterine peristalsis. Very beautiful paper on uterine peristalsis. Go through that paper. Now, I'll probably do one more slide also. So I'm not going to go through this. Yeah. The uterine peristalsis are of two types. There are junctional zone peristalsis and there are myometrial peristalsis. The junctional, how the embryologically, the Mullerian ducts develop. The Mullerian ducts come in front and they unite to each other. And Mullerian ducts are the one which develops into fallopian tubes, the uterus, cervix, and the upper 1/3 of the vagina. The myometrium is not a part of Mullerian duct. The myometrium is surrounded mesenchyme, which surrounds the Mullerian duct, and that is your myometrium. So there is nothing, the myometrium contractions are different and the junctional zone contractions are different. Junctional zone is the most important zone from the reproductive point of view, because junctional zone is of Mullerian origin. Junctional zone has the radial plexus of vessels, your uterine ascending, descending, straight, and then radial plexus. Okay, and then ascending, descending, arcuate, and then straight, and then you have radial plexus, and the spiral comes from the radial. Junctional zone where the endometrium basalis is there, which develops the endometrium stratum compactum and stratum spongiosum, which gets shed off in menses. Basalis has stem cells. See, imagine the importance of junctional zone. So if I see a uterus and I don't see a junctional zone well, I'm really worried about her pregnancy. Unfortunately, it is not part and parcel of any reporting system by sonographists. They don't mention about junctional zone. So it's very important. And herein, if you want a pregnancy in your IVF cycles and IUI, you want your junctional zone to be quiet. Okay, that is very, very important. So stratum endometrium subvascular, subendometrial, only contracts in uterine peristalsis. It is not painful. Outer layer contracts, that's when dysmenorrhea and everything takes place. Okay, I'm not going to go through that. So a transvaginal scan will tell you junctional zone peristalsis very well. You just be stable, you'll be able to identify it beautifully. Fundus to cervix in early follicular phase, later cervix to fundus, more on ipsilateral side of the dominant follicle. The God is so beautiful, God is so great. And uterosacral ovarian countercurrent system is there. Since both sides of the uteri originate from different Mullerian ducts, ipsilateral contractions are possible. So we don't say that it is possible that way. Factors influencing the peristalsis: endometriosis, okay, increase ectopic endometrial cells produce estradiol, which leads to increased contractions. Leiomyoma will disrupt the uterine peristaltic waves, and hydrosalpinx, again, because of vectorial problems, there will be different peristalsis. Even I have not mentioned here the niche, the Caesarean niche. Okay, even that is one of the mechanisms. It disrupts the peristaltic wave, and that is one of the reasons of infertility with a patient of niche as well. And this is a paper about atosiban and piroxicam. Now, I'm quite against all this. I'm just putting it up. Atosiban doesn't make a difference, the forex plot. Piroxicam in some patients, yes. Atosiban doesn't. I really don't know why we want to relax the myometrium. We want to relax the junctional zone. And junctional zone relaxation is possible only with progesterone. So give good amount of progesterone, junctional zone will relax. And this study came from Robert Casper et al. He published a study. He called a patient a day prior to embryo transfer. He did a 10-minute scan, and in a patient who had 3 contraction waves in 10 minutes, all of them he gave intramuscular 100 milligram of progesterone on the previous night and improved the pregnancy rate. It is difficult to follow this system in my clinical practice, but after reading that paper, in all our hospitals, we are giving intramuscular oil-based progesterone morning to every patient who has frozen embryo transfer cycle, because we want to assure a junctional zone quietness. Because our transfers are different. Dr. Shari will tell you, we do transfers by late afternoon. They are not done in morning. So they give about 4 to 6 hours they get for the progesterone action to be there, and the junctional zone does become quiet. 35% decrease in uterine peristalsis in the first 5 days after vaginal progesterone. So, just if you depend on vaginal progesterone, and if you're doing blastocyst transfer or duphaston, we really don't know how much it has an effect. You have to use the parenteral progesterone to have a good junctional zone quietness. I will take this slide and then we will finish it off. We'll retire for lunch. How many of you chase thyroid? How many of you believe that we have to have thyroid less than 2.5? All of us believe. All of us practically, isn't it? Even I used to believe it till the time I came across this particular paper. And now I'm surprised why in conferences they are not including this particular paper. That's why I particularly included here. All that data is false. All that data of chasing thyroid to get a better pregnancy is completely false. And we'll just dissect that up. Scientific practice guidelines, so many practice guidelines are published on thyroids, Endometrial Society, not endometrial, Endocrine Society, American Thyroid Association, ASRM, everybody. But for this guideline published in 2024 by ASRM, rest all guidelines are recommending chase the numbers, keep the TSH less than 2.5. The philosophy behind that is, once you start stimulating, you are going to cause estrogen goes up. With estrogen goes up, it causes synthesis of thyroid binding globulin in the liver. So thyroid binding globulin goes up. With TBG going up, it binds to T4. So all the T4 is bound. Now pituitary senses low T4 and it starts secreting TSH. So your TSH goes up. So if you have a TSH level of 4 prior to ovulation induction, you go through ovulation induction, she gets pregnant, her TSH would be 5. And we associate our miscarriages and all that thing with that kind of. So pregnancy increases your TSH levels in the first part because of this particular mechanism, especially if somebody who has undergone multiple ovulation induction or ovarian stimulation cycle, TSH is bound to be high because of this particular mechanism, which is completely a false alarm. It's not to do anything with the pregnancy outcomes. So this is what I just told you. This is the guideline of 2021 European Thyroid Association, and this is what we follow. And still in the conferences they keep telling the same story, but this is a dead story. So there are few studies which change the scientific understanding as we understand after 2024. This is one study called Tablet study published in UK. This is a study 2019 publication. They had 972 euthyroid TPO, thyroid peroxidase antibody positive, and they were kept on L-thyroxine just because their TPO positivity, not because of, they were euthyroid. TPO positivity were treated, TPO non-positive were not treated. And at the end they said no significant differences in the outcome from the pregnancy point of view. So there is no point treating only TPO positive population, just on TPO positivity. This person did the problem, Rahman et al. Study. He published only one study, Egyptian study. So I don't trust Egyptians. People talk of Chinese, but Chinese are fantastic in their publications. 2011, treating subclinical hypothyroidism in ART women improves. He said it improves ART pregnancy and reduces miscarriage. It's heavily criticized for gross statistical errors. And Cochrane 17 did not even include this study in their publication. And all the other societies missed that Cochrane has not included the study. So Cochrane, but there is no communication. BJP Congress, so hota nahi hai. So in this particular Rahman et al. Study, we went through that study. TSH, T3, T4 were measured, not TPO. Subclinical hypothyroidism patients randomized to treat group 1, placebo in group 2. So all subclinical hypothyroidism, that means your TSH levels are around 4, 5, 6, they treated it up. 3 months prior to IVF, levothyroxine was given in group 1 with 50 microgram and long protocol IVF did. And they said 70 women, 35 in each group, TSH, but subclinical hypothyroidism का वो level था. And fertilization high in treatment group, miscarriage low in treatment group, pregnancy delivery high in treatment group. So they said subclinical hypothyroidism, you must treat it 3 months prior to IVF and it gives a phenomenal result. Okay, you're not going to see this. He said this is the group A, 9 miscarriages, 35 pregnancies, 26 live birth. यहाँ पे 13 miscarriages, 10 pregnancies, 1 live birth. ये कैसा statistics हो गया? Okay. So gross mistake. The whole statistics was completely wrong. But this one study skewed the whole meta-analysis. So meta-analysis results are always to be taken with salt, a pinch of salt, because meta-analysis depends upon RCTs. Your RCTs are very important, not the meta-analysis. So this is a subclinical hypothyroidism paper, prospective cohort study of effects of aspirin. This is actually the eager data, what Sherry was telling you about. And TSH beyond 2 points. So this is a study on pregnant women for giving low dose aspirin, nothing to do with thyroid. This is a secondary analysis of that study, which talks that TSH beyond 2.5 did not have an increased risk of pregnancy loss, decrease in live birth rate or fecundity compared to TSH less or more than 2.5. They said subclinical hypothyroidism in a wide study doesn't make any difference at all from the pregnancy outcome. No neurointellectual problem in the offspring was seen. Okay, so stop treating subclinical hypothyroidism in infertile population. Universal screening did not result in decrease in adverse outcome. Treatment identified thyroid hormonal abnormalities during pregnancy results in a significant decrease, only if it is a overt hypothyroidism. So RIP thyroid testing. From 2015 to 2024, there is no need unnecessarily to treat, you do thyroid, because otherwise there is no way to diagnose overt hypothyroidism. Okay, we can't wait for myxedema to develop, but there is no need to treat subclinical hypothyroidism. This is the guideline in 2024 published by ASRM, and says subclinical hypothyroidism not associated with obstetric parental problems. TSH is normal, no problems at all, no screening, no treatment needed, no TSH screen for pregnancy unless there is a thyroid disease, thyroid surgery, autoimmunity, or there is a thyroid disease in the family. No need of screening for infertility patients. RPL, test for TPO, otherwise no need to test. 2.5 cutoff is correct for overt hypothyroid. To keep patient who has overt hypothyroidism, keep the TSH less than 2.5. But subclinical hypothyroidism, there is no need to test it up. Now the problem is, you have started treatment for subclinical hypothyroidism in somebody, then you read this article and now you want to change your practice. So this is the problem today. That so we have to do a shared decision making and discussion of risk and benefit. We have to tell them, few patients will be happy not to chase thyroid number. They say, good, I don't have to do every 3 months test now and the pill is off. Any hypothyroid symptom is there, you can say, stop your treatment of this hyperthyroid symptom, Educating patients and providers must be there, and RPL is not a part of the guideline. So you have an RPL patient with hypothyroidism, well, that's not a part of the guideline. So when shall we test anti-TPO antibody? Isolated TPO antibody in a euthyroid, very low miscarriage rate, we don't know how detrimental it is, no test to be done. Thank you so much, we'll wait here.